Professor J. Srinivasan, in the absence of our chairman, Professor S.K. Satish. Professor Srinivasan is a graduate of IIT Madras 1969. He did his MS in State University of New York and a PhD in Stanford University. And is the founder of Digestive Center Climate Change and a past chairman for 11 years. And emeritus distinguished professor of DCCC till date. And also, he was the lead author of the second and fourth IPCC report on climate change and the reviewer editor on the third report. His major scientific contributions are in the area of monsoon models and climate change. He received Lifetime Achievement Award by the Ministry of Earth Science in 2019. He's a man with, I know him for the past 3.5 years, he's a man with values, discipline, simplistic way of life, with a helping hand always, anywhere in academic, and he has such a great academic zeal, and he wants to propagate the knowledge for the societal benefit. And also, I like to say that the Nobel laureate Sir C.V. Raman was his uncle. Sir, we have a great pleasure seeing you, and please go ahead, welcome the chairman and the speaker and the people, sir. Thank you.
Thank you, Dr. Parmesh. On behalf of Professor S.K. Satish, I welcome you to this monthly seminar series organized by Dr. Parmesh on various issues related to health and environment. And today we are tackling a very important issue related to cancer of the intestine. And I'm very happy that we have a very eminent doctor, Dr. Shivaram, who's going to give the talk. I request Dr. Parmesh to introduce the speaker. Thank you.
Okay, sir. In continuation of Professor J. Srinivasan, I welcome you wherever you are. Good morning, good afternoon, good evening, good night in the Commonwealth countries. So, Digestive Center Climate Change Institute of Science and Indian National Chapter of the ComHead UK and Lakeside Education jointly organized to celebrate the National Colorectal Cancer Awareness Month. This is the month. So, in this context, we organize this measure to mitigate intestinal cancer. So just making a few introductory remarks, and the intestinal cancer, it is a member of circumstantial environmental exposure to carcinogens has definitely been linked to the increased risk of cancer. Over 2/3 of cancer are related to environmental causes. Good news is most of them can be prevented. Most cancer are not hereditary, but from change in the lifestyle such as dietary habits, tobacco smoking, excess alcohol consumption, infection influence the initiation. Advancing age is the most important risk factor for cancer. In India, 87 out of 1 lakh population are the cancer. It is the 9th in the list of cancers in India. Prevention can be see your doctor if there are signs of change in the bowel habitat. Traditional food, whole grain, fruits, vegetables to be encouraged. Regular exercise, control your weight, reduce smoking and alcohol. To talk about this important subject, we have one of the eminent speaker and surgeon, Professor H.V. Shivaram. He did his graduation from the oldest medical college in the state of Karnataka, Mysore Medical College, and was a gold medalist in MS General Surgery in Bangalore Medical College. And he did the FAIS in India and a fellowship in Glasgow, and also American Academy of Surgeons in USA. He was the director of bariatric metabolic surgery at Astor CMI Hospital, and he is currently heading the department also. He has 30 years of experience in surgical profession, teaching, training, and research. His skills in gastrointestinal tract laparoscopic surgery are very well known. He has published research articles in index journals, peer-reviewed journals, delivered many orations, and authored chapters in surgical textbooks. He has also served in the Army Medical Corps as a captain and was awarded as a Sainya Seva Medal. He also received Doctor of the Year Award 2017, Rotary Gold Medal Award, and Dr. Mahadevan's Award. He was the first Rotary President. And he is a surgery postgraduate teacher for a national board and has trained many surgeons across the country and those from abroad in gastrointestinal and minimal access surgery. He is a member of the various national, international professional bodies and executive committees, both national, state level. Recently, he has been elected as the president of the Karnataka State Chapter of the Association Surgeons of India. To chair this session and moderate and a concluding remark, we have with us none other than another important person, Dr. Anand Kumar Jairam. He is a graduate from the Bangalore Ambedkar Medical College and did post graduation in Bellary. And he got many fellowships in laparoscopic surgery in the Indian Association of Gastroendosurgeons. He has served in surgery for the past 28 years and is a senior consultant at St. Philomena's Hospital for more than 20 years and also Suguna Hospital for 13 years, postgraduate teacher, guide and examiner to students of Diplomat National Board uh, and National Board of Examination, the former associate professor in surgery in the PES Institute of Medical Sciences and Research in Kuppam. He has several interests in complicated and recurrent hernias, abdominal and thyroid, breast, anorectal, and laparoscopic pelvic surgery. And he is also a good tennis player. We play tennis in the morning at Century Club. Very fine gentleman, thorough gentleman, and with humility, he treats with patients so compassionately. Many of the Century people have become close friends of him rather than his patients. He's so close to them. Having said this, Anand Kumar, I'll hand it over to Professor Anand Kumar. Go ahead, take over and introduce the chairman and start the subject. Over to you, Anand Kumar.
Anand, you have to unmute.
You have to unmute. You have to unmute Anand Kumar.
Good evening, sir.
Yes.
Am I audible?
Yes, yes.
Good evening, sir. Thank you very much for the invite to chair and moderate the session on measures to mitigate intestinal cancer. As I know Dr. Shivram for more than 30 years, he's been one of the pioneers in GI surgery and pancreatic surgery in southern India, and he has traveled across India and the globe, and he's got a very rich experience and academic knowledge to share us about the measures to mitigate intestinal cancer. I thank the members of DCC and Dr. Parmesh especially for his kind words and introducing me. Now I hand over the mic to Dr. Shivram.
Thank you, Dr. Anand and Professor Paramesh. Anand, my slides are visible?
Yes, sir.
Thank you. Thank you very much. First of all, let me thank the Divecha Center for Climate Change, Indian Institute of Science, and the COMAD National Chapter and the Lakeside Education Trust for this kind invitation. Professor Paramesh is my guru and also mentor. When I was just having my foothold in the field of surgery, he took me to Lakeside Medical Center and also guided me in my professional career. Many thanks to you, sir. And also, we can never forget your kind and compassionate, always love and affection towards young people. And we are all thankful to you. Thank you, Professor Srinivasan, for giving this honor, and Indian Institute of Science. I have given previous talks also, and a lot of patients from Indian Institute of Science come to our hospital, that is the Aster CMI hospital. Always we try and do our best. I have nothing much to disclose except that I am the head of the Department of Surgery and Allied Specialties,
in this great institution, that is Aster CMI Hospital. Thank you very much, Professor Paramesh, for that kind introduction, and Anand for your kind words. Intestinal cancer is one of the most important cancer. It is because there are, as Professor Paramesh put it, a lot of things can be preventable. So when there is an element of prevention, why can't we take the benefit of this? And when we speak of intestinal cancer, it is mainly we are speaking about the large intestine, that is the colon and rectum. When we say mitigation, it essentially means reducing the severity of an occurrence. So let me put it in two parts, that is the measures to mitigate the risk factors of the intestinal cancers, and a little bit about if at all someone develops the intestinal cancers, what measures we can do to reduce the severity of the disease and the suffering of that patient. Colorectal cancer in the world, this is the third most common malignancy and the second most deadly cancer. Fortunately, this is not so in India, as Dr. Paramesh put it. It is not the third most, it may be coming around 9th or so. The global burden of this cancer is very, very huge. But in India, as it is economically and socially, everything getting integrated with the rest of the world, the number of colorectal cancer are increasing every year. So it is estimated about 4.4, it may be now a little higher, 5.1 or so per lakh population per year is the incidence in our country. If you see this chart, among the top 10 countries with highest incidence of colorectal cancer, that is in 2020, India is one amongst them. And the projected in rates for about 2040 is also here. So this is definitely increasing. Compared to other countries like China, Japan, Korea and all, it may be less, but what we have to worry is the number of cases which are rising every year. As Professor Paramesh said, when we were studying in Mysore Medical College, we never heard of colorectal cancer that much. And somebody, if diagnoses a colon cancer during his exams or so, the examiner used to look at it as if we don't know anything, because that time everything was tuberculosis and tuberculosis in the abdomen. The past scenario, if you see, the incidence was low and the detection used to be late because of the facilities were low. Genetic screening was not so much available as it is available today. And the primary mode of the treatment was surgery, and not much of chemotherapy or radiotherapy advancement was not there. And even in the surgery, it was not laparoscopy or robotic surgery, it was all open surgeries and the big scars in the abdomen. And the post-surgery care was also poor because ICUs and other facilities were not so much developed. And the stoma care, if when we do a colon surgery, sometimes we may create stoma in the abdomen where the motion will be diverted. That care was also not so. Even overall awareness amongst the medical doctors or the population was low. But this scenario has totally changed as of now. We see that the incidence is increasing. That's the importance of this talk. Maybe Professor Paramesh has taken it. Early detection is possible at present. The screening methods are definitely better. We have many of them. And it's not just surgery. There are multimodal management of this dreaded disease. And laparoscopic and robotic surgery have become the order of the day, that way mitigating lot of suffering of the patient. Good home care services are available now. Many patients can, after their post-operative care can be done at home. Stomach care is one of the best in our country at present, especially in cities and the rural areas. Still, there is it is not so much available. Public awareness definitely with the efforts of organizations like these, public awareness is definitely increasing. So if you see this, last about 20-25 years, lot of changes have occurred in our country in the scenario of colorectal cancer. But as we learn more and more, we have also learning that the colorectal cancer in India may be a little bit of different type compared to the rest of the world. According to the Tata Memorial paper, this disease occurs at a younger age in India. More signet-ring tumors, that means they are more aggressive and more resistant to treatments. And in the colon, we have right-sided colon and left-sided colon. Right-sided colon, the prognosis, it is easy to treat. Left-sided tumors are more dangerous and many times require stomas, and that kind is much more common in India. And when they present, they are presenting in the advanced stage, not able to detect it in the earlier stage, so that ultimately the suffering and also the mortality is higher. And more malnourished patients we see in this category of patients of the colorectal cancer. If you see the digestive system of the human body, when we eat food, it goes through the esophagus to the stomach and then to the small intestine, and from there it goes to the large intestine, and then it comes to the rectum and through the anus and becomes feces in the colon and then comes out. So this is again what I said, that is the stomach, the small intestine, and this portion of the colon we call it as the right-sided colon or cecum ascending colon, transverse colon, and the left-sided large intestine, and here it is the rectum and then the anus. So when the disease occurs in this portion of the large intestine, the available route to evaluate is through the anus. That is, we can do endoscopy going through the anus and then go to the entire part of the large intestine up to here, and we can evaluate. That is the greatest advantage of preventing. If we have to detect and also prevent, we have the advantage of doing an endoscopy through the anal route in these cases. So what initiates cancer in the large intestine? This is a very difficult question to answer, because even with lot of research, we know very little about it. Exact cause, if I say, is not yet very certain. What we know is that it begins when the healthy cells develop some changes. We call it as mutations in their DNA. So when the DNA, when something goes wrong and something mutation occurs because of various factors, which some of us we can discuss later, the healthy cells always grow and divide in an orderly fashion. But when the cells of the DNA gets damaged, it becomes haywire. It becomes continuously growing, accumulating, excessively uncontrolled growth, causing a tumor. With time, these cancer cells can grow and then can invade and destroy the normal tissue around it. Not only that, they can go to the other parts of the body, which we call it as metastasis. So it can go from the colon to the intestine, to the liver and rest of the part of the body, and can create become an untreatable disease. So as I said, it all starts with one cell or so, then gradually becomes increased in the colon or rectum. It becomes, initially we call it as a small polyp or a lesion, then it invades or destroys the tissues around the colon, and then from there it goes into the lymph nodes, and from there into the liver and other areas. So accordingly we call it as stage 1, 2, 3 or 4 in the cancer stages. So early stages always treatable, probably curable. So to understand who are at high risk to develop colorectal cancer, so there are some things which are beyond our control. So that is people who are more than 50 years, and the male gender, and the ethnicity. Especially it's very common in African Americans. If some families have the colonic cancer or polyps, then it can run in the family members. So it's very important to be aware that any of our seniors or relatives in the family had colonic cancers or polyps. Inflammatory bowel disease, it's not irritable bowel disease, that's a different thing. Inflammatory bowel disease like ulcerative colitis and the Crohn's disease, especially the ulcerative colitis, can after many years can turn into malignancy. So people who are having ulcerative colitis, they have to be screened periodically and checked up. There are certain genetic syndromes which are associated with the colorectal cancer, and also type 2 diabetes. People who are having type 2 diabetes, they are more prone for colorectal cancer. So this we call it as non-modifiable risk factors, or the risk factors which we don't have much control what we can do. But on the other hand, see, these are inherited genetic syndromes which are runs in the family. Most of these things are medical terminologies, so that's why I will not go through this much of it. But colorectal cancer can run in the family, and family history of developing colon cancer is very important. There are other factors which call it as modifiable risk factors, means the risk factors we have under our control, and we can try and avoid these risk factors so that we can prevent this deadly disease. Especially the smoking. Smoking can initiate the DNA changes in the cells in the colon. So smoking is a very, very high risk factor. Not only for cancer, there are many 20 to 30 diseases which are associated with chronic smoking and for the long term. Excessive consumption of alcohol, again, that is can initiate the cancer cells. High consumption of red meat, this is another important factor. High consumption of processed food instead of raw food or the readily available food. If you use more of processed food, more of red meat, they are all risk factors. Low intake of fruits and vegetables. So if you are not having enough roughage in our diet, the obesity, again, obesity is a risk factor for many of the cancers, and one of the important is the colorectal cancer. Physical inactivity. The person is not active, not spending his time in the daily activity, especially to maintain his good health, again, that is risk factor. So what I want to tell you is that these are all under our control, and these are all the things which we can do very much to prevent the colorectal cancer. And if you see here how the smoking affects a normal cell it can turn into increased cell growth and the the DNA changes and can initiate mutation and the cancer cells. Especially similarly, alcohol also can aggravate whatever has been initiated and cause more damage. Physical inactivity, increased body size, that is obesity, the Western diet of meat and processed food, and the diabetes, all these contribute to the increased incidence of colonic and the rectal cancer. After knowing what are the important risk factors and how the cancer can start, we should also know which are the symptoms of early cancer so that we can mitigate it at the bud itself. When we have these symptoms, these are all red signals. So blood in the stool or in the toilet after having a bowel movement. So that is important to observe and also report to the doctor. Dark or black stools, that also can be a sign of cancer in the colon. Change in the bowel habits, that is, you are having every day 1 or 2 stools and suddenly you notice that you are passing 4 or 5 motions and sometimes blood stained, or the shape of the stool, especially when the cancer grows and it has to come through the narrow passage, the shape of the stool can change, it becomes a narrow. So any of these changes, if we notice, that should be taken care and should not be ignored. And also the cramping or discomfort in the lower abdomen. So pain of certain types, which is not lasting 1 or 2 days, but continues for a few days, then we should not ignore it. Any urge to have a bowel movement when the bowel is empty. You pass motion, come out, and still you feel something is remaining and you are not happy that you have emptied the bowel. That is the urge to bowel and feel that bowel is not empty. That is also very important sign. All this happens because something is happening inside the colon or the rectum. And this may be when the motion passes, it can bleed and that can make the blood in the stools, or because it is growing, it can cause pain, or it may change the stool consistency or the shape of the stool. All these things should not be ignored at all. But don't panic, because some of these things can be because of some other things also, like infection, and sometimes people think whatever happens in the motion passage or below, it's all because of piles. But important thing is to report to the doctor and have a thorough checkup. So after understanding the early symptoms are very important to not to ignore, because that is the time the cancer can be treated and probably cured of this problem at all, for a lifetime. But when if you ignore it and late symptoms of intestinal cancer starts, that is little risky to treat, like excessive fatigue. That means it has gone beyond the colon to other areas, unexplained weakness, unintentional weight loss. So weight loss without any reason, changes in your stool that last longer than a month, feeling that your bowels won't completely empty, and if it is totally blocking the intestine, patient may not be able to pass motion and he may start vomiting also. So we should not go to these stages. We should diagnose early and then treat. So what tests to diagnose? So this is again very important to go in an orderly fashion, not that you just go, you think there is probably I have a cancer in the colon and go and get a CT scan or MRI. That's not the way to go about it. The first and foremost important thing is to go to a good clinician or a surgeon and get a thorough examination done by the doctor. When you go and when the doctor suspects anything, he will do a digital rectal examination. That means he will put a gloved finger into the anal passage to the rectum and examines. So when he examines, if he sees any tumor or feels any tumor or he sees any blood in his finger, then he may advise further tests. Also, he will take a thorough history of what is happening to the patient. Certain blood tests are required if to know whether there is anemia or other things. And the next most important test is a colonoscopy, which I am explaining a little later. And in the colonoscopy, if any lesion is seen, the doctor will take a biopsy of that lesion and send it for testing, and that can confirm or it can say that there is no tumor. That is the ultimate proof of having any cancer or not having a cancer. The imaging studies may be required like CT scan, MRI, PET scan and all. After all these things is confirmed, and then further treatment has to be planned. Colonoscopy is a very, I won't say simple test, but very important step in preventing, in screening the patient, and also diagnosing the colorectal cancer. It can be done under sedation or anesthesia without much discomfort to the patient, and usually done by the medical gastroenterologist or a surgical gastroenterologist. It captures the in a monitor all the videos of the colon, and we can see and then take further action. So you can see here a clip of the colonoscopy, how the medical gastroenterologist can go into the colon when the patient is sleeping or under sedation. It doesn't cause much of discomfort. The entire colon, as I showed earlier, can be visualized easily by the doctor through this colonoscopy. So this is a very, very important step to understand the colon, what is happening. And if there is any polyp means it's a small, we can say as a lesion. This is the precursor of the cancer in the colon. If it is more than 1 centimeter in size, and if there are more than 3 in numbers, and they are known as the adenomatous polyps, they may harbor cancer. But nothing to worry. Even if it harbors, if we find it at this stage and take out this polyp, that itself may be curing the initial stage of the cancer, and this is known as the snare polypectomy, which is done using the low voltage electricity. And after removing this, we send it definitely for histopathologic, that is the biopsy examination. So as I told earlier, the cancerous growth starts as a very small lesion because of the damage to the DNA, and if it is growing without any control, it can grow further and spread to the intestinal colon wall, and from there to the rest of the body. So that's why it's very important to find out in the early stages by doing the tests. One of the greatest advantage we have in the colon and rectal cancer is that we have time, and not time that 1 year or 1 month or like that. We have about 10 years duration. This is very, very important. You see the normal epithelium, normal lining of the colon here, and this is where it starts, known as the hyperplasia, then known as the adenomatous polyp, and then it comes into adenocarcinoma. This takes about 10 years, sometimes 15 years also. So even if we detect at this stage, this is 90% chance of survival in the stage 1 and 2. So this is the greatest advantage we have in the colorectal cancer. This advantage we may not have in many of the other cancers in the body. But when it becomes bigger and it invades to the other areas, whatever treatment we give, that is stage 3 and stage 4, the chances of survival for a long time is about 20%. So it has to be this month, the colorectal awareness month every year in the March, is basically to make everybody aware of this portion of the advantage we have in the colorectal cancer. So how is the screening done? The screening is the most powerful tool for preventing colorectal cancer. It's a process to detect polyps and any other lesion in the large intestine that can be treated before cancer develops or spreads. So this is what is screening, and some of the countries where the incidence is very high, this has become a mandatory to be done in all the health checkups. Small lesions, as I said, develop into cancer. It may take 10 to 15 years. That's why the importance of screening. And when we do regular screening, these polyps which are there can be found and removed, and the chance of them turning into cancer is totally prevented. And even if the cancer is detected early by screening, they're curable, as I said, and colorectal cancer deaths can be reduced to more than 60% by doing proper screening methods. So what are the screening methods we have? We have very simple test that is called the fecal occult blood test. That is the stool test. Just a simple stool test can detect cancer in the colon and the rectum. So this looks, as I said, when this lesion bleeds, it can come in the blood. It may not be very obvious. Sometimes it may not be red or black, but it may be in very small quantity, but we can make out by doing this FOBT test in the laboratory. How often to be done? It was to be done once a year. If it is positive, then we have to do colonoscopy and confirm it, because there are some other lesions also can, or some other injury to the colon by some other things can also cause little blood. So that is not because of the colon or some other non-cancerous lesion. So that's why colonoscopy becomes very important. So if it is negative, so another 1 more year it can be peaceful. There is no worries at all. If you do colonoscopy, another 10 years you can be peaceful. So screening is mandatory in certain countries, but in our country it is not yet become a must in screening these diseases. Prevention, again, endoscopic methods. The flexible sigmoidoscopy, it means we are checking only up to this portion of the colon, that is sigmoid colon. So this area is more prone for cancer. So this can be done once in 5 years. But when we do a colonoscopy, we are going and checking the entire colon. So, and if there are any polyps or anything, we are removing it. So this can be done once in 10 years. There is also known as virtual colonoscopy, that is the CT scan colonoscopy. This is not so accurate as colonoscopy, so it has to be done at least once in 5 years. So the best method is the colonoscopy and then the other methods. So it is good to go for colonoscopy than the other methods. Now there are newer concept of screening tests, some of the blood tests which are biomarker for the cancers. These are also available, but all these things have to be finally confirmed by the colonoscopy. Colorectal cancer genetic testing. This is important in patients who have family history. These are now available in our country also. Other thing what we should remember is what is not useful for screening. So CT scan is not useful. Sometimes it may be harmful for radiation. MRI scan, PET scan, blood test, urine test. So many patients bring all these reports and tell me whether I have cancer or not. So that is not useful at all. Very methodical. Measures to prevent colorectal and intestinal cancer. So this is very important, what all we can do, which are under our control. Stop smoking if you want to prevent colorectal cancer. Moderate your alcohol intake than excessive consumption. Maintain an ideal body weight than having obesity or other things. Physical activity, at least 45 minutes to 1 hour physical activity is very important every day. This releases a lot of good hormones like endorphins, and the prevents any of the malignant possibility also in the colorectum. Take high fiber diet, fruits, vegetables daily. So many people say I take it once a week or so. That's not useful. Better to make a habit. Daily multivitamin, folic acid, calcium. Some of them, there are reports, they are useful, but doubtful beneficial. So we cannot 100% recommend them. Where there is a high risk, some people who have polyps and all, we do what is known as the chemo prevention. That is the low dose aspirin, 75 mg per day, like that. Also people who are having the family history of polyps, this can prevent the polyps growing and turning into malignancy. Most important is to go for screening as we recommended in the previous slides. So all these are the measures which can prevent the colorectal cancer, intestinal cancer, with the environment getting worse and worse, and the eating habits of people becoming more and more towards refined food, and also a lot of chemicals in the vegetables we eat, the fruits we eat. All these things are affecting very badly for the increase of cancer. Eat to live. Sometimes we eat so much as if we are not, as if we are living only to eat. So, but if you want to live longer, live healthy, better to eat less, and also better to eat healthy, high fiber diet than the very high processed food or the red meat. This is just to show you how we can prevent the colon cancer by doing a colonoscopy. And when doing a colonoscopy, if a polyp is found, this is called a polyp. It looks big, but because of the magnification, and this polyp can easily be removed within few minutes by the endoscopist, and that area is made little bigger by injecting saline adrenaline, and then this is looped into a snare, we call it as. To that, the controlled electricity can be passed, and cautery burn, we call it as. So then we can easily remove it by taking it out from the attachment into the colon. So this growth which has started and probably may be there for 2-3 years or so has been removed completely, and then this is sent for histopathological or biopsy examination, thus preventing this going and becoming a big cancer or spreading to the wall of the cancer or going to the rest of the body. So that is the importance of doing colonoscopy and also removing these lesions. Let me touch upon some of the measures to reduce the severity of the disease if at all someone develops, and how to mitigate his suffering. Most important is, once you detect that there is some cancer in the large intestine or so, don't think that you can hide it by family members or anybody. That way you are doing much more harm. So don't be in a denial mode. Many people think whatever bleeding occurs in the motion, it's all because of piles, and they go to some of the quacks uh, in that area. They get piles treatment, and then finally they come to the colonoscopy or so. It has become untreatable. That should not happen. Most important to identify, diagnose, and then only treat the disease. There is no effective alternative system of medicine at present, even after diagnosis. So it's very important to first diagnose and then treat, than blindly treat the people who are having the blood in the motion, in the notion that it is all piles. Depends on the stages of the cancer when we have to manage the colorectal cancer. In the initial stages, it may be just removal of the polyp, or maybe a laparoscopic or robotic surgery. That itself can help. But nowadays, we treat many of the rectal cancer. We treat with initially give chemotherapy, radiotherapy, reduce the size of the disease, downstage the disease. If it is 3-stage or so, we can downgrade it to stage 1 or 2, and then do the surgery. This has good long-term disease. So to decide all these things, we always have a tumor board meeting, sitting along with the medical oncologist, gastroenterologist, oncosurgeon, anesthetist, everybody, and then decide what is the best way to treat the colorectal cancer in that particular patient who has presented with different stages. There is no harm in taking second opinion if you have doubts about it, or even if you want to take one opinion you have taken, you can always take second opinion from another surgeon or another cancer surgeon and see that what best can be done. Our principles of management in any cancer is most important is whenever possible we want to cure it. Whenever it's not possible to definitely cure, we definitely control it, which is possible in most of the time by all the methods available now. And even if we cannot control and we have terminal stage, definitely comfort is most important, and we all give most important, that is the comfort always comes even if we cannot cure or control. In these settings, the stomach care is very important. When we remove certain portion of the colon, when we have to do surgery, we put what is known as the colostomy of the stoma. Earlier, we didn't have all these good stoma bags and stoma care persons. We have definitely have a lot of good advantage. It doesn't smell. If somebody has to go for it, if it is required, we have stoma care people, excellent stoma bags, and also people can take bath, everything, and have a normal life with these good stoma care. Also, home care is now available to mitigate the sufferings of the people. Even we can make ICU at home in the terminal stages if it is required. Somebody don't want to stay in the hospital. Teleconsultations has become a norm of the day after the COVID, and home care assistance, lot of home care services, companies are available, and there are a lot of people, especially in urban areas, where we can have good home care services. So friends, March is the colon cancer awareness month. If there is good awareness, 60% of the colon cancer deaths can be prevented with screening and creating awareness. So let us all see that good awareness is created. It has taken the toll of many of the famous personalities, whether they are in film industry, sports, or the politics, but there is definitely hope. Let us all join the fight against the colorectal cancer. We'll create awareness. I must appreciate the Devicha Center for Climate Change, Indian Institute of Science, the COMAD National Chapter, and Lakeside Education Trust, and especially Dr. Parmesh for this talk and creating awareness. And preventable, it is preventable in early stages, and if it is little late, definitely it is treatable and we can control it. And finally, it is definitely beatable if we all put our heads together. Thank you very much, and thanks a lot for this kind invitation. And many of my terminologies may be medical. It is, we are used to talk to medical personnel. If there are any questions or doubts, I'm sure myself and Dr. Anand and Professor Parmesh, we all try to clarify. Thank you very much. Thank you, sir.
That was an excellent presentation by Dr. H. V. Shivaram, sir. Thank you very much. You have had an exhaustive session, starting from the risk factors, the severity of the disease, the past and present scenario, and the early stages, and what are the early symptoms which can't have been more aptly emphasized. You talked about the early detection of fecal occult blood and blood in the stools, and also the importance of catching the disease at the early stage so that complete cure is possible. You've also spoken exhaustively about the diagnostic importance, the starting from a good clinical examination, digital examination, proctoscopy, then going on to diagnostic modalities like sigmoidoscopy or colonoscopy. Also, the timing of the detection of tumor can't be aptly emphasized. Also, you have brought about very important the fecal occult blood test, which is very important, which can be done to detect early and prevent the spread of disease. You have given a good emphasis on the modalities of treatment available and how an early diagnosis can achieve complete cure. Over to you, Dr. Parmesh, sir, and if there is any questions, we can take forward.
Before any questions, I want everybody put their camera on. You can like to have a picture. So this will be going to on our bulletin. Please, all of you, put your camera on. Thank you. Okay, Pradeep is over. Now it's good to see Professor Rawat from Nagpur and being there, and he's one of the mentor of the COMAD organization. And Professor Dr. Soumitra Anathan is also there. So nice seeing you, Professor Rawat.
My pleasure, sir. My pleasure. Thank you.
Okay. So, any questions? Please feel free. Professor Srinivasan, any comments, sir?
I want to ask you, you know that India is one of the countries with the highest air pollution. So the risk of air pollution in India, is it as serious as smoking as far as cancer of the colon is concerned? Has anyone worked on it?
As far as I know, basically it affects through the smoking. So the other pollutions is basically the risk factor for the lung carcinoma, and for the colorectal, I am not very sure. Not many people have worked on that, I think, but it's a very good point what you have raised, sir. The pollution in the air, basically it can affect any of the body cancer, but particularly for the colorectal, I'm not aware of it. Anand and Paramesh, if you have.
There are some studies, sir, which have said on an average, countries with poor environmental quality have 40 more cases per lakh than compared to developed countries. So where poor air quality and smoking is a factor, even intestinal cancers are higher by about 40 per lakh cases.
Poor quality of.
Yeah, poor air quality.
Yeah, I want a clarification. Suppose you people have good data about the incidence of cancer in various cities in India. You can plot that against the data available today on air pollution. I would like to know whether there's any correlation. There may be other factors, of course, but for example, my suggestion would be that Delhi should have the highest incidence of this cancer on account of high air pollution compared to Bangalore, for example. So can that be analyzed? And the data is there. We can ask Satish to get the data on air pollution and we can compare it.
That is available, sir. There is Indian Cancer Registry, which has the data of all the cancers. The problem is only thing that there are registries in the regional cancer centers, like in Kidwai in Bangalore, the Tata Memorial in Delhi, and certain states may not be having the cancer centers, and some of the reporting there may be a problem. So that is the only problem. Otherwise, the data is available. Every cancer we have to report and it has to be recorded, and the Indian Cancer Registry is maintained, sir, in cancer institutions.
Okay. Thank you.
So can I ask a question?
Please go ahead.
Yes, madam, go ahead.
Yeah, following on Prasad Srinivasan's query about air pollution affecting colorectal cancer, is there any relationship between water contaminations which could cause this increase in colorectal cancer? And the other question that I have is, you told about inflammatory bowel syndrome, which could be the causative agent or one of the symptoms. How does one differentiate between inflammatory bowel syndrome and irritable bowel syndrome?
That's a good question.
Yeah. Irritable bowel disease is not a pathological entity, it's a functional disorder. When I say functional, means when you irritable bowel disease, you do a colonoscopy or a test or anything, you will see a normal colon. You don't see any of the pathology in that. But in the inflammatory bowel disease, which is ulcerative colitis or a Crohn's disease or non-specific colitis, all those things, when you do a colonoscopy or you do a test or anything, you will see lesions in the colon, which can be biopsied, and we can confirm, yes, it is inflammatory bowel disease. In the irritable bowel disease, you may have cramps, you may have diarrhea, you may have sometimes constipation, all these things, but they are not correlated by the tests we do, and that's how we rule out the inflammatory bowel disease, and that we call it as functional bowel disease or the irritable bowel syndrome. Hope I made the point clear.
Yes, sir. For this, thank you. But the earlier question that I had, have we got any data on biological contaminants, geogenic contaminants in water being causative agents for increased intestinal cancers?
Anand, you want to take up that?
No, we don't have any such data about water contamination and intestinal cancers.
Thank you, sir.
Professor Rawat?
It's fine. An excellent lecture, really, after many webinars. Congratulations, Dr. for
Thank
your
you, sir.
excellent presentation. Really wonderful. Thank you.
Hope it was useful, and hope it will help to prevent some of the colorectal cancers, and it will spread the awareness about this disease all over.
Thank you.
Okay.
Dr. Ravi Kumar, you have anything to answer?
If Ravi?
No, sir. No, sir, nothing.
You always have some question.
No.
It's keeping the people on their toes.
Nice to see you, Ravi.
Hello, sir.
So If there are no questions, we will request our secretary of our organization, Ravi Kumar, to give the vote of thanks. So,
Hi, good evening, everyone. Dr. Shivram, it's the first time I'm listening to your lecture. I've seen you in action in Aster. Nice to see you, sir. Nice to listen to you. It was an excellent lecture. Dr. Anand Kumar, thank you for moderating the session and for your kind presence. Dr. Srinivasan, as always, thank you, sir. Dr. Rawat, thank you for joining from COMAT and representing
Thank
COMAT organization. And thank you all the participants for your time on a busy day after your work. And as always, this has been an excellent session to raise awareness on preventive aspect of what we are focusing on. And I will say, hopefully, there were a lot of takeaway points. This lecture is being recorded and it will be shared by Daivicha Institute. I hope you'll be able to share with other family members. Sir, Dr. Shivaram, I want to say it was not too medical. I think it was quite simple enough for common man to understand. So
Yes,
I'm sure, hopefully, they will learn and change their lifestyle. Today, interestingly, we were discussing about constipation. When we read constipation in medical school, it was just a passing comment. Somebody sick in bed, post-op, maybe they had some constipation. But when we went to UK, it was a big business. And now we come back to India, and now we are seeing once again it's a kind of future. Probably we can have experts in constipation like we had in UK. It's unfortunately we are copying the Western lifestyle and obviously paying the penalty for it. I hope people will wake up and change their lifestyle. And with this few words, I'll say thank you very much, Dr. Shivram, Dr. Anand Kumar, and all the members who have been here today. Thank you.
thank you.
you. Good
Professor
night. Good
Professor
night.